Welcome to the webinar, The First 1000 Days in the Nordics, Identifying Gaps and Needs to Strengthen Psychosocial Wellbeing. I'm happy to host this, act as your moderator today. My name is Kaisa Lähtemäki-Smith, and I'll moderate the discussion. And I will remind you all also at the same time that this webinar is recorded and will be available for at least about 2 weeks in Nordic Welfare Centre's web page, as well as Itla's web page. Very exciting to hear these results and findings, and especially to discuss them then in the panel. If you have questions or comments during the event, you're welcome to put your questions and comments in the chat. And do that, then we can see if we have a few minutes at some point to also raise issues or questions from the audience. But without further ado, we will have the opening of the event, or official opening, from Director of Nordic Welfare Centre, Eva Franzén.
Good morning and good afternoon to some of you all around the Nordic countries. On the behalf of the Nordic Welfare Centre, I have the great pleasure to welcome you to this webinar, which is organized by the Nordic Network about the Child First 1000 Days, a healthy start in life. My name is Eva Franzén, and I'm the Director of Nordic Welfare Centre. For those who are not familiar with us, we are an institution under the Nordic Council of Ministers for Health and Social Affairs. The mission of the Nordic Welfare Centre is to contribute to development of measures in the welfare sector in the Nordic region and serve as a platform for Nordic cooperation. We do this by compiling and disseminating knowledge and research, organizing seminars and webinars and conferences, supporting and coordinating working groups and networks. One of the networks that we are pleased to support is the Nordic Network about Child's First 1000 Days in Life, a healthy start in life. The network was founded in 2023 to follow up the recommendations that were developed during the first 1000 days in the Nordic countries project. This was a 3-year project founded by the Nordic Council of Ministers, in which the 5 Nordic countries, Denmark, Finland, Iceland, Norway, and Sweden, participated. Today, the network is composed of representatives from the national health authorities, competence and knowledge centers and foundations in the 5 Nordic countries, as well as we at the Nordic Welfare Centre. The Nordic Network has a mandate until 2027. And the goal of the network is to strengthen collaboration that support children's development and well-being during the first 1000 days in life. The network does this through strengthening the knowledge sharing, supporting systematic use of evidence approaches, and strengthening the implementation capacity across the social welfare and health care system to promote children's well-being from pregnancy to the age of 2. As demonstrated by research, this stage in a child's life is a crucial period that lays the foundation for the child's well-being and development, but also for their health and well-being later in life. Identifying children and parents in need of support and ensuring that all children and families receive the best support possible during their early years of life through early interventions and early childhood and parenting programs is therefore a priority for the network, the Nordic countries, and the Nordic Council of Ministers. The work of the network thus contributes to the implementation of the Vision 2030 agenda for Nordic Council of Ministers, as well as United Nations Agenda 2030 for Sustainable Development, both which recognize that good mental and physical health for children and their family is essential for the child's life development and well-being. Today, the network is launching a new report. The title of the report is The First 1,000 Days in the Nordic Countries, Identifying Gaps and Needs to Strengthen Psychosocial Wellbeing. The report is funded by the Nordic Council of Ministers. I very much look forward to the presentation of the key findings of the report and the following discussion during this webinar today. So once again, warm welcome.
Thank you very much, Eva Franzén. And it's great to hear that this is only a beginning of the debate and dialogue over this topic. I hope many of you had the opportunity to peek at the report already, but now we will hear from the horse's mouth, so to say. So our two researchers will present the key findings of the report. So I'm happy to welcome senior specialist from Itla Children's Foundation, Jonna Lehikoinen, and clinical teacher, speech and language pathology, and a senior researcher at Faculty of Medicine and Faculty of Educational Sciences, Marjaana Raukola-Lindblom. Please, the floor is yours.
Thank you, and thank you for all joining us to the launch of the new The First 1,000 Days in the Nordics report. The aim today is not to go through the full report in detail, but to highlight some key findings, frameworks, and implications that may be interesting from policy, system development, and implementation point of view. The report itself is more comprehensive, and we warmly encourage all the participants to explore it further after this session. My name is Jonna Lehikoinen, and I serve as Finland's second representative in the Nordic network. My colleague here is Marjaana Raukola-Lindblom, and we have worked together on report at Itla. As Eva already told us, the Nordic network about the child first 1,000 days, a healthy start in life, brings together experts from all Nordic countries and the Nordic Welfare Centre. The network works under the mandate from the Nordic Council of Ministers, and it was established at 2023 as a follow-up for earlier Nordic project. The work of the earlier project showed that while Nordic countries are very well positioned to ensure optimal conditions for child development, have a strong universal health and social services, some important gaps still remain. Based on these findings, the mission of the network is to strengthen Nordic collaboration by sharing and developing ideas and experiences, promoting research and knowledge about the first 1,000 days of life, and support implementation of evidence-based psychosocial interventions, and also explore some Nordic joint training and mentoring of evidence-based approaches. This report we are now going to represent is part of the Nordic project that was funded for 2025 to 26, and it was funded by Nordic Council of Ministers, and it was coordinated by Itla Children's Foundation in collaboration with Nordic Network. It aims to strengthen the systematic application of evidence-based methods within social and healthcare services, and also increase the implementation expertise across the Nordic countries. The background for the report is in the fact that the first 1,000 days are the critical window for lifelong health and well-being of child and also the adults. And the importance is well recognized in research, policies and practices. The first years in child's life are essential foundation for development of lifelong health and well-being, and the robust evidence demonstrate that early experiences affect health and well-being as well as behavior and social relationships in later life. Each Nordic country has its own structures, healthcare and social services, which all include prenatal and infant services and the guidelines that emphasizes supporting child's health and development, as well as the parent-child relationship and from the pregnancy onwards. They also emphasize the systematic identification of risk and early response for them. Despite this, psychosocial needs are not always identified early enough, and many commonly used interventions lack strong evidence, and the evidence-based methods are not implemented consistently across the countries and regions. For this reason, the report is framed through the implementation perspective. The report aims to support better alignment between identified needs, available evidence, and everyday practice.
To briefly outline the main objectives of this report, first, we aim to identify the psychosocial needs as well as key risk and protective factors during the first 1,000 days. Second, we mapped effective evidence-based psychosocial interventions to understand what is already working as well as to identify the gaps. Third, we focused on how to support systematic, high-quality, and sustainable implementation across the Nordic region. Finally, we also explored the use of the WHO's new maternal well-being framework by applying it to organize our findings. And this acted as a pilot application, allowing us to assess how useful the framework is in practice. Briefly about the materials and approach behind this report. First, the literature on risk and protective factors was reviewed by an external research actor focusing on meta-analysis and systematic reviews, and those relevant to low-threshold psychosocial support and preventive approaches during the first 1,000 days. The aim was to identify the most relevant and actionable factors in Nordic contexts. And we reached over 160 articles of meta-analysis and systematic reviews. Second, evidence-based psychosocial interventions were mapped through selected Nordic and international online intervention information portals that assess effectiveness. We included interventions rated as effective or at least promising, while also recognizing that evidence continues to evolve by time. We found 28 effective or promising interventions assessed in Nordic portals and 18 additional from US or UK portals. Third, Nordic expert discussions played a crucial role and highlighted the importance of how support is organized in practice. We conducted thematic analysis of these discussions. This was complemented with international guidelines and guideline reviews, and also situation analysis that was reported 2020. Finally, the synthesis was made using parental well-being framework based on the framework recently published by WHO. We used this well-being framework to clarify the reviewed key needs to match these with existing interventions and expert discussions. This made it possible to identify gaps, not just missing services, but areas where further development and evidence are needed.
In this report, as Marjaana said, all the findings were organized using this maternal well-being framework, which is a definition and conceptual framework. It provides a shared structure for integrating 3 different sources of evidence. According to the framework, maternal well-being is a positive and dynamic state that extends from the pregnancy until 1 year after pregnancy and shaped by wider social, relational, and structural context in which parents live in. Well-being is therefore not seen as an individual trait alone, but as something that is influenced by access to support, resources, rights, and care. A key strength of this framework is a multidimensional nature. It brings together both subjective well-being, such as emotional experiences, and objective well-being, such as living conditions, health services, and social relationships. This is relevant for implementation because psychosocial support is always delivered within the real-life conditions. The framework consists of 6 interconnected domains: health and nutrition, relationships and connectedness, safety, secure and sustainable environment, autonomy, agency and resilience, culture and values, and the provision and experiences of care. Rather than treating these as separate areas, the framework highlights how challenges in one domain often affect the others. Importantly, the framework moves the focus from preventing mortality to actively promoting overall well-being. This is relevant in the Nordic context, where the basic health and security is largely secured, but the psychosocial stressors and inequalities in service experiences still remain. Nordic experts emphasize that this framework is relevant for both parents and caregivers. For this reason, the report refers to it as a parental well-being framework. From child's perspective, all caregivers' capacity to provide safety and responsiveness is shaped by the same domains. Using this framework, therefore, supports the evidence synthesis and gap identification. Based on the literature review we made for this report, the key finding is that parental mental health cannot be separated from other aspects of well-being. The reviewed evidence consistently shows that mental health is intertwined with all domains of well-being, including physical health, family relationships, living conditions, agency and resilience, and cultural context, but also the experiences of care. Mental health both shapes family life and is shaped by it. Even mild symptoms, if left untreated, can affect well-being of parents, bonding and everyday caregiving, with consequences both parents and children. The review also showed that perinatal mental health challenges are diverse and rarely have a single cause. Across the studies, symptoms such as depression, anxiety, and stress-related often co-occur. These are frequently associated with earlier mental health problems, experiences of trauma, perinatal losses, or negative or insufficient care experiences. The evidence indicates that these factors tend to accumulate, increasing psychosocial strain for the families. The reviewed studies highlighted that the mental health of both mothers and fathers or non-birthing parents is relevant. However, the review also shows that paternal mental health problems are often under-identified despite the clear associations with family well-being. From child's perspective, the literature emphasized that early caregiving relationships are central. Infants' emotional security and development are closely tied to emotional available and responsive caregiving. Early exposure to high parental stress, unresolved trauma, or mental health difficulties is associated with increased developmental risk for children. Taken together, these findings from the review indicate that parental mental health must be addressed holistic and integrated way. In addition to literature review, expert discussion conducted for the report remind that the importance of parental mental health and highlighted the need to address it at as much earlier states across the care pathways. Experts also emphasized that if left unrecognized or unsupported, parental mental health problems can in most severe cases have serious and long-lasting consequences for parent, children, and wider family system. The evidence underlines the importance of early and systematic identification of a wide range of mental health risks. Risk factors are rarely isolated. They are often connected and gives the unequal social conditions are creating very different starting points for families. Poverty, low income, unemployment, or other insecurities are linked with a chronic stress and higher risk of mental health problems in both parents and children. These conditions affect daily life, caregiving capacity, and also access to support. Findings also highlight that immigrant and minority families often face additional burdens such as language barriers, discrimination, and weaker social networks. These factors increase psychosocial strain and make it harder to receive timely and appropriate care even within the universal service systems. In addition to these disadvantages, violence and parental trauma have a role in inequalities in the perinatal period. Intimate partner violence and parents' own adverse childhood experiences are structurally patterned and often co-occur with other inequalities, and these tend to accumulate over time. This proposes that the need for early and systematic identification of violence and trauma are trauma-related symptoms. When families experience several adversities at the same time, risks add up and can persist across the generations. This is relevant from the psychosocial perspective because stress, mental health difficulties, and limited support tend to reinforce each other. At the same time, at the right side of this slide shows some protective factors that can buffer these risks. Supporting parental mental health, coping skills, and resilience helps protect family well-being. Supportive partner relationship, positive parent-infant bonding, and strong social networks are powerful buffers against adversities. So services should be designed to recognize a cumulative risk and respond proportionally for those. Interventions also need to be integrated, flexible, and accessible.
And looking at the intervention landscape, we identified 28 evaluated psychosocial interventions in Nordic context. And most of these focus on maternal depression or general parenting support. However, there are clear gaps. For example, current evidence-based interventions focus on limited challenges, with most evaluated interventions targeting in these maternal depression and general parenting support, while several recognized mental health difficulties remain weakly covered. We found no effective evaluated interventions specifically addressing conditions like OCD or eating disorders or traumatic childbirth experiences, even though these can be highly relevant in the perinatal period. Also, neuropsychiatric challenges of parents were not targeted in these intervention programs. We also observed important relational gaps. There are no targeted programs focusing on coupled relationships, mental health of fathers or partners, loneliness, or support for single parents. Also, risk of violence is poorly targeted. In addition, migrant, refugee, and minority groups, such as sexual or gender minorities, are largely missing from the evaluated interventions. Overall, the intervention landscape reflects what tends to be studied and diagnosed, especially maternal depression. This points to a structural mismatch between needs and the current evidence base. At the same time, there are promising interventions, but more Nordic effectiveness research is needed to better respond to these gaps. And what is important to address, a lack of evidence does not mean a lack of support in practice. This is a snapshot based on current online evidence portals, and the field is, of course, continuously evolving. In this report, each domain of parental well-being framework section includes a table of interventions checkmarked with identified needs based on the literature. This report highlights who current interventions are actually reaching. and who may be left out. Most interventions are primarily targeted at mothers, especially focusing on depression and parenting support, like also support for early interaction. These areas are also widely studied and recognized in literature. The interventions are also often targeted to other secondary goals in addition to the goal of the target group mentioned as primary. However, several groups are underrepresented. Fathers and non-birthing parents are largely missing, as are many minority groups, including migrant and refugee families, cultural minorities as Sami, LGBTQ+ families, and parents with their own health challenges. We also see that families with multiple or overlapping risk factors do not necessarily gain access to support, even when their needs are high. Access to psychosocial support is shaped by several factors, such as service accessibility, regional differences, cultural appropriateness, and also awareness. For example, how well mental health issues are recognized and understood, and whether people know how to seek help. Here you can see the intervention gaps that were identified during this report. As noted above, we noticed a consistency in the areas where no research was found. However, we must remember that we only included meta-analysis and systematic reviews, and the selection of interventions depended also on the online information portals we used. So this is not a totally comprehensive overview. You can find this table in the report as well. When these findings were discussed among Nordic experts, the overall message was quite consistent. First of all, everyone emphasized how central parental mental health is, and especially the need to identify problems earlier and respond sooner in maternity and child health services. What also came through quite strongly is that these challenges are not just clinical. Parents are facing a lot of broader pressures at the moment, things like stress, loneliness, financial strain, and issues like screen time, polarization, and climate concerns arise. Experts also pointed out that there is still a gap between what we know from research and what actually happens in everyday practice. Another important point was that fathers or partners' mental health really matters. It's not just about the mother, but about the whole family. Still, there are no systematic screenings of partners or fathers' mental health or cumulative family risks as well. There was also a clear call for clearer care pathways and more stepped care approaches, so support would be easier to navigate. Experts noted that services often break at key transitions. They also recognized a need to strengthen training and professional competence across the services. It was also noted that when what gets studied gets attention and other needs can too easily remain in the background.
During the report process, we noticed the need for the stepped care model, as Marjaana pointed, and that's something that our experts also emphasized a lot. So in this section, we connected our report findings with international guidelines from organizations such as WHO, NICE, and COPE. These guidelines are very consistent in recommending stepped continuum of perinatal mental health care. Care should start with the universal services for all families, include targeted preventive support for those at risk, and ensure timely access to specialized services for parents with moderate or severe mental health disorders. Importantly, the focus is not only on symptom reduction, but on family well-being and the quality of early parent-child interaction. Research also highlighted the value of early prevention identification, routine screening for both parents, and structured follow-up. Studies show that family benefits, for example, the guidance during the transition to parenthood, strengthening the social support and low-threshold psychosocial support. From Nordic perspective, much is already in place. All Nordic countries have a strong universal services, routine screening practices, and emphasis on early detection and family-centered care. However, expert discussions highlighted that perinatal mental health care is still uneven. Services are often fragmented, implementation is not consistent, and access varies by region. Experts also noted growing concerns about long waiting times, limited access to psychological treatment, and clear gaps in service systems. One critical gap that was raised by experts is the lack of specialized mother-baby units and specialized care teams. Without them, parents with severe mental health conditions may be separated from their infants during the treatment. Taken together, evidence from guidelines, literature, and expert discussions support the relevance of stepped care model for Nordic countries. The guiding principles in the model are presented, such as family-centeredness, trust and continuity, empathic and non-judgmental care, and also supporting cultural and linguistic accessibility and support for autonomy. So the next step presented in the report is that the Nordic countries appear to face quite similar perinatal psychosocial risks, yet to currently assess and implement interventions using some sort of different criteria. To respond to these challenges, the report outlines the possible next steps at Nordic, national, and regional levels. These should be understood as proposals for further development. At the Nordic level, the findings suggest that developing a shared assessment and implementation model for psychosocial interventions could be beneficial. A shared model may support scalability, quality assurance, and consistency, especially for the rare, high-risk, and minority groups where the evidence within individual countries is often limited. Future developments should prioritize building consistent care pathways and implementation process that support this stepwise model, thereby strengthening effectiveness, equity, and long-term improvement in perinatal services. The selection of interventions integrated in stepped care models should balance effectiveness and suitability, considering cultural relevance, resource requirements, and organizational capacity. A shared Nordic assessment framework would support collective understanding and help identify common solutions to shared challenges. Here, the parental well-being framework appears to offer useful contribution. It provides a shared theory-based structure for examining needs and interventions across multiple well-being domains, rather than focusing only narrow clinical outcomes. Nordic collaboration could also help avoid duplication of development work and support the generation of more robust evidence through the pooled learning. The findings also propose that strengthening knowledge exchange in Nordic countries and joint training could add some value. The report shows some gaps between evidence and practice and points to some shortcomings in the implementation structures. It acknowledges equity considerations and complexity of contextual factors while emphasizing the need for cross-country collaboration and resource pooling to strengthen implementation efforts across the region. At the national level, it points towards the importance of alignment needs and readiness. Evidence alone doesn't translate into impact if care pathways are unclear and fragmented. The maternal framework may help countries review their systems domain by domain and reflect where the current pathways support parental well-being and where the gaps may remain. the explicitly including culture, values, and care experiences as domains, the framework helps make inequities more visible. This may support the development of culturally sensitive and accessible services for parents with disabilities, sexual and gender minorities, and immigrant families so that equity considerations are embedded with the care pathways. This report can support alignment between Nordic collaboration, national system development, and regional practice. A coordinated Nordic approach can provide a strong basis for improving service equity, strengthening the quality, and supporting sustainable, context-sensitive implementation for young children and their families. And finally, we would like to take a moment to express our sincere thanks. First, we would like to thank the entire report working group. Rosa, Jemina, Eli, and Terhi, thank you. Your dedication and expertise and genuine commitment made this work possible, and the process has been marked by thoughtful collaboration and shared purpose. We would also like to thank Nordic Network about Child's First 1000 Days for its insights, cooperation and encouragement throughout the process, as well as the national networks and partners for their active participation and valuable contribution. Our sincere thanks go to the Nordic Council of Ministers and Itla Children's Foundation for providing the resources and support that made it possible to carry out this report and to strengthen Nordic collaboration around the first 1000 days. And finally, we would like to thank our friends and loved ones who has patiently listened to more than fair share of the topic. Their support has mattered more than they may realize. If you have any questions, reflections, or would like to continue the discussion, please feel welcome to get in touch with us. Thank you for listening us.
Thank you.
Thank you so much, Jonna and Marjaana, for your excellent presentation. And as you said yourself, the social support networks, as well as being important for the first 1000 days, are obviously very important when making such a significant report and addressing these really interesting and important issues. We thank the report authors and the whole team. And next, we have the pleasure of discussing further what the results, what kind of implications they provide, how are they interpreted in the different Nordic countries. I have the pleasure next of welcoming our panelists and present them briefly and to hear from the different country cases. We have Josefin P. Jonsson, Head of Department, Lifestyle and Health Promoting Environments, Public Health Agency of Sweden, representing Sweden. You get a little bit of a Eurovision feeling here. Then we have Helen Brandstorp, Divisional Director of the Division for Municipal Services and Emergency Preparedness, representing Norway in the panel. Helga Sifridjovsdottir, Ph.D. and Deputy Director General at Ministry of Health in Iceland. And last but not least, our Finnish representative, Reija Klemetti, Director, Children and Young People's Unit, Ministry of Social Affairs and Health in Finland. So a warm welcome to each of our panelists. I will address each of our panelists by kind of first name basis here. So Josefin, Helen, Helga, and Reija. And we've agreed on some basic questions that we will discuss, but each of the panelists obviously is free to raise issues that you feel necessary and relevant and particularly important in your national context. Having heard the presentation by Jonna and Marjaana, I'm sure many of you had lots of thoughts, and I think I would like to hear first from our panelists which findings from the report resonate particularly in your country And we have also agreed that each of the panelists can also contextualize a little, so say a little about the national context in this area of research. For instance, in the Finnish case, we agreed with Reija that Reija should say maybe a few words about the recent changes in the Finnish system of children's and families' well-being, the social and health reform, which has clearly, obviously, implications on these issues that we are discussing today. And please, Reija, I think, would you like to start and address this first question of which findings from the report resonate most in the Finnish case, and maybe give a little bit of a context to the Finnish case?
Thank you very much, and thank you for inviting me here. And especially first, I like to thank about this report. It's really needed, and I appreciate it. And then shortly about this Finnish new system, our health and social welfare service reform, which came force into 2023, reorganized services into 21 well-being services counties and city of Helsinki. And if we think child and family services, this creates important opportunities for better integration, both horizontally between health and social services and vertically across levels from basic services to specialized care. However, as the reform is still recent, its full impact is not yet clear. And I think that the increased autonomy of the well-being services counties in organizing the services is both a strength and challenge. It allows for more flexible, locally tailored solutions, but at the same time raises concerns about whether services will remain equitable across the country or begin diverse to the local priorities. But then shortly about these findings from the report, I think that the most urgent issues in Finland is generally the gap between the universal coverage of primary maternity and child health services and access to targeted treatment-oriented perinatal mental health support. And we have data that minorities in Finland in generally access maternity and child health clinic services well. But for example, migrant parents cannot be treated as a single category. Engagement tends to be lower among those facing socioeconomic or psychosocial stress. And for non-birthing parents, we offer as extra so-called extensive visits, but because their participation is still selective rather than systematic, their mental health, stress, and early interaction with the child are not assessed as consistently as mothers. So, as a conclusion, I think that the key issue is no longer access to perinatal mental health services alone, but whether services are sufficiently responsive to trauma, diversity, and cumulative disadvantage. Thank you.
Thank you, Reija. What about the Swedish case then, Josefin? Would you like to continue? What were the issues that were particularly pertinent for the Swedish context from the report?
I'd love to. Thanks for first of all, thanks for the great job done within the network with the presented report, and of course also a big thank for the opportunity to represent the Public Health Agency of Sweden in this panel. And in Sweden, we strongly resonate with the report's findings on inequities in access to perinatal care, both between regions and among different family types. And as I see it, three critical challenges stand out. And the first one is the regional disparities. Despite our national child health care program, we see variations in how families are reached, especially postpartum, where engagement among non-birthing parents drops. And this, of course, of course creates unnecessary inequities in the essential early parenting support. And the second challenge is related to perinatal mental health gaps, also described in the report. And in Sweden, we lack standardized risk assessments, unified training for professionals, and specialized teams for complex cases, and this often leads to mother-child separation during treatment, which is detrimental to both. And then the last challenge is exclusion of minority groups, already mentioned here. And we have insufficient knowledge and tools to support LGBTQ plus families, Sami communities, and immigrants. And our interventions are rarely culturally adapted. So as we see it, we must involve all parents early and develop shared tools and training and ensure that minorities are included in designing interventions, and we see great Nordic added value by collaborating. We can address gaps no single country can solve alone.
Thank you, Josefin. Very relevant highlights from the Swedish case. What about Norway? Helen, would you like to continue? Does the picture from Finland and Sweden, is it similar in the Norwegian case?
Yeah, I think so. So first, I want to express my appreciation from the Norwegian side, from the Directorate of Health, and for this report and the work of the Nordic network. I think it's highly valuable. And as a fun fact, one of the first research projects was from the northern part of Norway, late 60s, regarding how it was Anders Forsdal. He showed that how poor or nutritional poor a childhood would come out as poor health later in life. So, and then we know that excellent researcher in Helsinki has worked extensively on that issue later. So it's very, for me personally, being a GP from the north earlier, it's very interesting to listen to these, what's done nowadays. So although we have strong system and extensive knowledge from our side in Norway, we are not yet fully translating this into early, coordinated and targeted support for the children and families who need this most. This is particularly urgent now because the inequalities persist, even within a well-developed welfare system. We do try, but we can't, reach it, and we have had the knowledge for nearly 60 years. We even have a pretty new Norwegian white paper addressing many of the same challenges identified in the report, especially inequalities, fragmentations of services, and the need for earlier intervention. But it mainly outlines planned solutions. The key question going forward is whether these ambitions translate into consistent and equitable implementation. We are also taking steps, for example, by developing updated guidelines for postnatal care with a stronger focus on mental health, and by assessing the use of screening tools. In this work, we find the report highly valuable. But again, reports, research, knowledge, it has to come alive. And that's why I think working in a network, sharing ideas, seeing each other is so important. So again, thank you for the network's work.
Thank you, Helen, and we'll come back later on actually to the value added of Nordic collaboration, and maybe hear also how this particular project will continue. But Helga, what about Iceland then? How did you listen to the findings and read them? What was particularly pertinent for your case?
Thank you. First of all, thank you for inviting me to this panel, and also for the people who created the report. It's such a important piece to have to help us redesign the services in at least Iceland and all other countries. So the report strongly resonates with what is happening in Iceland, and specifically I want to mention the part that mental health, parental mental health, is a central determinant of a child's well-being, even in a country like ours where we have strong universal healthcare, and we are not so many. We're only 400,000. So it should be fairly easy or simple to create services that provide adequate parental mental health to support the determinants of a child's well-being. So I want to emphasize that from the policy level, the report kind of emphasized the fact for us that we need to have evidence-based and effective interventions, but we need to also think about how do we reach everyone and how do we make sure that the system works together. So, for example, in Iceland, we do have, like in other countries, screening for parental mental health in primary care. But then what happens when a person needs something based on the screening? And in the small primary cares out in the countryside in Iceland, this has been a challenge. So we screen, there's a need for mental health intervention for the parents, but how do we connect that with mental health services even within primary care? I recently had a meeting with the primary care clinics in the northern part of the country, and they are excellent at collecting data, which I've also, the report highlighted for me the necessity of collecting service data and understanding the processes and where are the kinks that we need to kind of sort out. According to their data, because they're really good at it in the north, almost half of parents in the prenatal services needed some form of support for mental health in primary care, which I thought was, I didn't expect that to be so much. So that for me, the reports from the policy level emphasized that I need to make sure that I'm constantly working on combining the systems and trying to have it run smoothly. And since I'm talking about systems, in Iceland, we speak Icelandic and we are behind on all different languages. So our healthcare is mostly in Icelandic, also information, etc. So that's one of the things that the report highlighted for me, working in the Ministry of Health, that we need to make sure that everyone is included. And then for the final piece, I also wanted to kind of highlight that in Iceland, we have passed legislation that is named or called Integrated Services for the Prosperity of Children, where the laws help us think about and kind of we are eligible to work together. So healthcare, social services, schools, etc. But the same challenges rise there. How do we share data? How do we communicate? How do we make sure that the systems, nobody falls between the systems? So we're just on the third year of implementing these changes that the legislation is making on all of the systems, and we have a lot of challenges working there. So for me, it was a really timely report, kind of encouraging us to continue working on these things because it's so valuable that we create this worth for the unborn children.
Thank you, Helga. So important. And I think this is certainly one of the key roles of such a report, is to raise the awareness and bring these issues to our attention and to the attention of policymakers who can then address these on a more systems level. I heard many of the themes resonating, the inequities of access, regional disparities, parental health gaps, exclusion of the minority groups coming from the different country perspectives. And the report is very strong, I think, for an external reader also on some of the points relating to the current service structures not being able systematically to reach the most vulnerable families, and that structural equality, multi-professional cooperation, and genuine political commitment are all needed. I heard those also in your comments, and I think addressing perhaps the health and well-being of children and families as a more kind of systematic, systems-based issue. The report also showed, and you resonated on how the risk factors accumulate and reinforce each other, meaning that the mental health, financial stress, loneliness, lack of social networks, discrimination, and migration-related pressures all are kind of come together, or they rarely come alone. Fragmented care pathways, cultural inaccessibility, and regional disparities once again came up as repeatedly as barriers. But of course, in order to address these barriers, we are also here to discuss what could be changed, how to address these through structural changes. Some of you have already addressed some of those, but I would like to maybe next hear a little more about the issue of how would you address this very difficult issue of high-risk families. If you could name, if you could elaborate, if you could imagine one structural change that would be most relevant or would make the greatest difference in your view, what would that change be? I saw Helga nodding, so I'm hoping, do you want to start, Helga, on from the Icelandic point of view, how to address the high-risk families in particular?
Thank you. So for me, I think it's good to be honest from basically the health ministry. I think that our system struggles to fully respond to the complexity of high-risk families. I also think that we are really good, or not really, but we are good at identifying individual risk, but much less effective when the risk accumulates and interacts with often other realities. So again, in Iceland, we do have universal service and early screening, but the support is too fragmented. And I also think that we are not mindful of thinking about evidence-based practice of understanding different needs of high-risk groups. And I want to emphasize that I think it's really important that we use frameworks such as the Behavioral and Cultural Insight Framework at the World Health Organization. So we actually use these frameworks to help us understand why doesn't the current pathways or service systems work, and how can we be more mindful of the differences of each high-risk group that we are trying to serve. And I want to bring an example from Iceland, which kind of highlighted this. We have the cervical cancer screening was transferred to primary care 3 years ago, and going through the data after the implementation year 1 and 2, we saw that women with migrant background were participating less, so they weren't coming. And so they used the framework, Behavior and Cultural Insight Framework, to understand what this was happening. The result was that the women that were partaking in the review said that most of them were working in jobs and they were not allowed to go to primary care appointments during the daytime. So the primary care clinics changed the service and said now they have one evening open specifically for this group. Obviously, other people, anyone else can make an appointment, but this was to meet their needs based on what was happening. So I think that we need to, in order to change systems, we need to make sure that we work with people. I want to borrow the slogan, nothing about us without us. I think it's so important that we work with high-risk groups on what works for you and how can we help it work better?
Excellent, thank you. A very, very nice concrete example from the cervical cancer screening and how simply changing the timetable and the appointments then could be of help. Would you like to continue on this topic, Reija, from the Finnish perspective?
Yes, I think that in Finland, as Helga said also from Iceland, that we are relatively good at identifying different risks, but not the cumulative risks. And this might, of course, also be because the knowledge is not going between the professionals. And I think that the one possible solution could be this family center model, which we already have in Finland, because it's a way organizing services around families rather than institutions. And it brings together healthcare, social services, early education, NGOs, and also parish-based family work, starting already from the pregnancy or even before it. And I think that that would be a good option to strengthen and further develop that, because it's not yet working so well in elsewhere in Finland. Thank you.
Thank you. Very once again, a very concrete family center model that could be expanded and could be then obviously studied more closely to show also the evidence of its impact and what difference it makes. Would you like to continue, Helen, do you have points from Norwegian side?
Yeah, so
also on how to better support maybe the well-being of all families, as we have kind of addressing here.
Yeah, so maybe I should have said this earlier, but so our child health clinics and school health system is on a municipal level, just like, the GP scheme. Every inhabitant in Norway has their own GP designated. And because of their proximity in the municipalities, and there are a lot of municipalities, 357, and half of them is 4,000 inhabitants and less. Because of that proximity, GP, child health clinic, I think when it works well, you kind of have the GP, the midwife, the child health clinic talking together and discovering families at risk. So it's really an ideal of a strong universal service and to all families. And of course, you have guidelines that regardless of background, everything, you should have equal support and follow up. And it's there as an explicit ideal, but I think it's of course not easily followed up. The report's finding on the invisibility of non-birthing parents and minorities also relevant in Norway. What we work on is to secure the GP scheme. So we have increased the number of GPs. We do work on improving the child health clinics, and user involvement is also essential in Norway, something we work extensively on. And because we need to continuously ask our users and get their response on how they experience our services. I think we also have to say that because we all share the indigenous minority Samis, and we all have at least Norway, Sweden, and Finland, not Iceland, maybe, a truth and reconciliation reports coming or almost done. So we have responsibilities both towards national minorities, other minorities, and the indigenous peoples. And I think that we try to share knowledge from a national perspective, But I think the local user involvement and on the national level would, give us more proof, and it's often very effective to have the user's voice. Thank you.
Thank you, Helen. Very important also to bear that in mind, and the importance of the service users and how they are involved. Are there any comments? Josefin, would you like to comment on the replies so far on these issues, or maybe on this local level, and how to involve the users in developing the services?
Well, I think that we, as in the Norwegian situation, we have 290 municipalities, and the responsibility divided between the national level, the regional level, and the municipality level. So I think that then we don't have the same system with designated GPs in Sweden. We have, so it's complex, but it's finding each other and also the different distribution, because municipalities they don't work the same way. They have a strong local political
and I think
governance.
Yes, exactly. Yeah. And I think the local and regional level, even though they're organized differently and with slightly different responsibilities, or even major differences between the responsibilities, but the fact that all of the Nordic countries share this large number of municipalities and local authorities with varying responsibilities, obviously, for health and social issues and families. But it is something that we have share and have in common. I think Finland has over 300 municipalities as well, even though now we have the new health and well-being counties as well. Very good points, and I think very interesting practical examples from our panelists so far. And I think in a little while we can maybe also see if there are some questions in the chat that could be addressed. I don't know. I think many people find it difficult to multitask, and that's fine. I find it really difficult myself. So I think many of the people haven't really been following all the links. We have at the same time also links popping up. So there are both Nordic and specific national materials and information shared online in our chat. And maybe in a little while, as I said, we can also look at if there are questions from the audience that our panel could address. But obviously, one more big question, and obviously in these Nordic projects, and as we've already heard, we share a lot. There are a lot of differences, but we also have a lot in common. And obviously, always with these Nordic projects, there is the issue of Nordic value added. Pohjoismainen lisäarvo, or nordisk nytta, as it used to be called, at least when I used to work in early 2000s in the Nordic context. And there was a lot about the Nordic value added in the report. The report argued that the Nordic collaboration generates real added value, particularly for developing shared knowledge base on minority and high-risk groups, where no single country has sufficient scale to build the evidence base alone. And as we saw, this building of the evidence base on the Nordic level is very, very significant and very relevant. At the same time, whilst the report also states that minority and high-risk groups, as we already heard, are poorly served by existing interventions, and certainly not all interventions have been studied either, so we don't have enough evidence even if interventions exist. So a Nordic shared approach is raised as something that could be more effective in some cases than singular national efforts. So Nordic value added could be finding more information and knowledge together. More than 60 interventions have been identified internationally, but only 28 have been evaluated in the Nordic context. And obviously this gives a nice boost for all the collaboration and projects working together after this report. But I would like to hear from each of you how do you see the report also puts forward an idea of a Nordic implementation, Nordic training model. It would be interesting to hear from you, how do you see that idea? But also maybe, I think more generally, I think it would be nice to hear that. How do you see the Nordic added value? How can we best gain from working together? Would you like to start on this question, Reija?
Yeah, I really like the Nordic model. And in Finland, we still have work to do, even at the universal level. But however, many things are still going on. For example, a new national project led by the Finnish Institute for Health and Welfare is currently being launched with funding from ministry. And its aims are, for example, to develop a high quality model for childbirth education and to systematically monitor birth experiences in order to improve them. And in addition, the Finnish Nursing Research Foundation is developing national recommendations on the care of fear of childbirth and low-risk pregnancies. And there is under consultation a government proposal for the reform of the Social Welfare Act. And it's proposing a new type of service for families and with children. And this creates a very important opportunity to rethink how support can be provided in a more integrated way across social and health services, avoiding overlaps and ensuring that early interaction professionals, such as psychologists, are systematically included in care pathways. And one thing still at the specialized level, there are also developments underway. For example, in the Helsinki University Hospital area, a new service is being established where a baby can stay with the mother during psychiatric specialized care, as suggested in the Nordic model. But this is just a start. So even though the economic situation in Finland is currently challenging, there is still a lot that can be achieved by organizing services in new and more integrated ways. And this is what we can do together in Norden. Thank you.
Thank you, Reija. What about the others? How about Helen? Would you like to continue on the Nordic value added from your perspective?
Yeah, in Nordic collaboration, I always think of same, but different. So, it's not that different, but it's a little bit different. So it's always added value, I think. And I think we think of a shared Nordic implementation and training model would be valuable, but also, but it must be built on common principles because of our autonomous municipalities. We need the local adaptation and freedom, flexibility to organize things in Norway. That's our mentality. And one way forward is to build on models that already work. We have a program called Tidlig In or Early In that provide training for professionals working with pregnant women and young children and supports municipalities in implementing early interventions. We see this as a useful model that could be scaled and adapted across countries. The main barriers are differences in organization, governance, local priorities, while key enabling factors include shared knowledge, development, common training frameworks, and continued Nordic collaboration. So to sum up, the key for us is the flexibility so we can adjust it to local needs. And I'm sure that we all share that as well. I'm now sitting in the Oslo region. It's so different from where I used to be a GP up on the Finnish border, close to Utsjoki. Utsjoki, yeah.
Exactly.
It's fascinating. It's strength. It's the cultural diversity that we need, like biological diversity, but it's it needs this flexibility. Thank you.
Excellent, and very much, I suppose, echoed by the other countries, and certainly in the Finnish case, we are always. I don't think any politician would start a speech without or a response without starting to say, Finland is a big country. But it is true that we are a big country, and the regional differences are huge. So that is true. Helga, would you like to resonate on the Nordic value added?
I think I agree with my colleagues here in the panel on everything that they said. I think the thing that I would wanted to add from the Icelandic perspective is I think it's the Nordic collaboration is particularly valuable. As you know, we are a small country and we have a small system. Also, both in healthcare, but not also in universities, research-wise. But we have this uniqueness, though, that we kind of are a tiny little laboratory. If you want to do a good implementation research in Iceland, you can argue that it's a good laboratory setting for a whole country. But so we definitely in Iceland, we benefit greatly from collaborating in such a collaboration. And like has been said here before, same. We share so much, but as I said before, we also need to be mindful of using then evidence-based practice to adapt to the needs of the Icelandic people and the diversity within Iceland. So use kind of people-centered approach or the behavioral cultural insight model to take the same and adapt it to Iceland, and also the high-risk groups that are within here. So I'm actually, like I said before, the report is excellent, and we very much look forward to continue this collaboration, and hopefully this will continue on because it's really, really valuable.
Thank you, Helga. Maybe also, I don't know if any of you have the response or are able to reply to this question at the moment, but there were some comments from the chat about, well, what happens? Are there plans or is there information about how the next steps of this collaboration will be or could be funded? So do any of the panelists, are you in the know in terms of what happens with this particular network and its collaboration? We weren't really prepared for the question. This just came from the chat, so I'm not sure if we have the ability to reply at this point. Please, Helen.
Yeah, I think I saw somewhere that we would take on the leadership for this collaboration. 2027. Norway would be sharing the network. So we'll have to dig deep into our pockets then, I guess.
Excellent. That's always good to hear. That's what I think us Finns always like to hear, certainly, that Norwegians, we don't have the money, but Norwegians have. So we're hoping, and in collaboration, I'm sure it can be organized. But really nice to hear that there will be continuation. I think it will be very valuable. I don't think there were any direct questions to at this point to the panel, but maybe one more round. If any of you have anything to share or to say, what would be the, how to make the report conclusions reality, or what will be the main takeaway for you from this particular report and the discussion we've had today? If you have any brief comments, or Helga, please.
So I just wanted to emphasize within the Ministry of Health here in Iceland, we are working on action plans both in mental health services, suicide prevention, and then also in health promotion. So particular health promotion because the focus of the government now is on children, adolescent, and mental health. So we are working on an action plan for determinants of health and health promotion. And I know that the Directorate of Health in Iceland, which one of the person who is the focal point for the collaboration, they have made sure that we are in the one of the actions is going to be redesigning parental mental health services and training for the healthcare providers that work there. So we're gonna, and that comes from this work and also the previous work on first 1,000 days. So it's really valuable and definitely putting its footprints on things and how we're doing things in Iceland. So thank you.
Thank you, Helga. Great to hear, I think. And the fact that it is implemented in such direct and concrete ways is excellent to hear. Do the other panelists, would you like to share your thoughts on this, or if there was something particular that you will take home with you to your work? Just open your mic in case you had a addition to Helga's.
My key takeaway would be that perinatal mental health services need to be more strongly embedded within the system.
Excellent. Thank you, Reija. That was really important. Helen?
Yeah,
please.
I think from my perspective, the key on these issues is to work across sectors. I'm from the health sector, so across the sectors, and not so across countries, but also across sectors, and that's to me. I'm involved, or we are heavily involved in cross-sectoral work, and to bring in the Nordic perspective would be really good in that work. And to move from knowledge to implementation, to be more, demanding on how to make changes, because we now have these fantastic reports. We have knowledge. Yeah, thank you.
Excellent. Thank you, Helen. Very good points. And from knowledge to implementation is a good move at this point. And I know that Itla and others and Ministry of Social Affairs and Health also is working a lot with this cross-sectoral work also in the Finnish case. So that's something that we also share. In case there are no other comments or questions from the panel, we thank the panel profusely for your honest and frank and fruitful, constructive comments and discussion. It's not easy to have a panel discussion online. I think I only see you as little dots there on the screen rather than us being in the same space. But I think we got lots of information and exchange already. So let's give a round of applause, everyone, to our panel, and thank you. Look forward to hearing how this work will continue. And obviously, we will also hear how the work will continue from the Nordic Welfare Centre's perspective. So after the panelists, we will give the floor to Jenny Ingudottir, who is the project manager from the Director of Health Iceland. So Jenny has the floor last, or is giving the closing remarks in our event. The floor is yours, Jenny.
Thank you. Thank you, Kaisa. And thank you to Jonna and Marjaana and all our panelists and everyone who has joined us today at this webinar. It has been so valuable to hear about the key findings from this report and to listen to the reflection from the panelists. The report gives us an important and timely overview of where we stand, what we already know, what is working, and where there are still gaps and where we may need to focus our effort next. The first 1,000 days from pregnancy to a child's second birthday are a unique and important period in a family life. It's a time of development, adjustment, attachment, and change. It is also a time where families may need support. We often speak about early childhood as an investment for the future, and of course it is. Supporting parents and children early can contribute to better health, well-being, learning, and participation over time. It is one of the most meaningful investments a society can make. But let us not forget that parenthood and early childhood has also value in and of itself, here and now. A baby's well-being matters today. A parent's mental health matters today. A family's sense of safety, dignity, and belonging matters today. These are not only foundations for later life, they are important parts of everyday life already. This also reminds us how important it is that families are met by services that are both accessible and supportive. Across the Nordic countries, many professionals are working toward this every day. By sharing experience and learning from one another, we can support that work and help strengthen the services we have around families. And this is also where the Nordic perspective becomes relevant. Our countries have their own strengths and challenges, as we've heard today, but we also share many similarities. We do have comparable systems, we have shared values, and we have many of the same questions about how we should provide equitable, timely, and coordinated support. Because our countries are relatively small, smaller as in inhabitants, the Nordic cooperation gives us a useful opportunity. We don't need to develop everything separately. We can learn from one another, build on one another's experience, and strengthen our systems together. This could include joint training opportunities for professionals, shared approaches to implementations and service pathways, and stronger Nordic research collaboration, so that we can build a broader knowledge base than any one country could create alone. By sharing proven interventions, comparing approaches, identifying gaps, and being open about what we still need to learn, we can move forward in a more informed and practical way while adapting the work to each national and local context. When we look at the importance of the earliest years, it's easy to think that this work should have been strengthened even earlier. But the most important thing is what we do now. The steps we take today can help create better support for families now and better conditions for children as they grow. And in a world that is often can feel uncertain, this work becomes even more important. It reminds us to keep our attention on what matters most in life: connection, care, health, dignity, and the well-being of children and families. The next step is to use this report and today's discussion as a basis for continued development, practical action, and lasting cooperation. This is also where the Nordic network about the child's first 1,000 days of life has an important role. The network gives us a shared space to exchange and promote knowledge, research, and understanding of how pregnancy and the first 2 years of life shape health and well-being. On behalf of the network, I want to thank the authors of the report at the Itla Children's Foundation. I want to thank the Nordic Council of Ministers and the Nordic Welfare Centre for supporting and promoting this important Nordic collaboration and for helping create the conditions for shared learning across our countries. I hope we leave this webinar encouraged by the knowledge we have, by the experience across our countries, and by the shared commitment to improve the support for families. We do have strong traditions to build on, and through this network, we have a valuable platform for learning and moving forward together. Thank you for your attention, your commitment, and your contribution to supporting children and families across the Nordic countries. Have a good day.
Thank you so much, Jenny. Thanks for the inspiring words. The most important thing is what we do today for tomorrow: connection, well-being, and dignity. I think this is a wonderful summary. I also, on behalf of us here in the studio and myself, thank you very much for attending this event. Thank you for all the discussions and comments. Discussion will continue. If you are sharing any of the findings or any of your musings, any of the thoughts online in social media, use the hashtag first 1000 days. And I also would like to highlight the fact that you will get a feedback survey, obviously, so that we know how to improve and what is needed for next time. So you will receive the feedback survey. The link will be in the chat, I think, and you will hopefully all have a chance to respond to that. So looking forward to hearing from all of you, and thank you for this afternoon.